All right, Harold, let's start.
Well, I suppose starting at the beginning would be a good place. And the first experience I had with brain stimulation, believe it or not, was as a graduate student at Oxford. I had completed an undergraduate degree at Columbia and received a fellowship to Oxford, where I did a second BA. And I had a lab that my first year there, which was taught by Edmund Rolls, who became one of the greats in the neurobiology of emotion and the physiology behind that. The first time I did brain simulation, had any exposure to it, was during a lab taught by Edmund Rolls in 1972, the fall of 1972 at Oxford. And I was taught where bregma was to find essentially the vertex on the skull of a rat, and to put an electrode into the pleasure centers and to have the rat self-stimulate, learn to self-stimulate. I don't remember whether the experiment was successful or not. What I remember was being blown away by the idea that animals would work relentlessly around the clock to produce an electrical signal that seemed to provide them with pleasure. It was addictive. And it was as concrete as you could get in terms of illustrating how electrical stimulation could change affect. Um, Going a step further, I did my PhD after Oxford at the University of Pennsylvania. And I was recruited there by Marty Seligman, the father of learned helplessness and positive psychology. But I chose to work with the Gours, Reuben Gour, who was a first year assistant professor. And the reason was Reuben was the only one member of the faculty that said I could do the research I wanted to do, which I had been working on the concept of self-deception and do people lie to themselves? And could I produce a laboratory illustration of this phenomena? Could I produce it in the lab and essentially prove that the body knew one thing, but the person was saying the opposite? That aside, that became in psychology a classic experiment and so on. But at the same time, Ruben and Raquel were studying laterality, and we're just developing the very first brain imaging techniques, working with inhalation to measure regional cerebral blood flow in the brain and positron emission tomography to essentially measure CBF and metabolic rate for glucose. And while working with them, I became intrigued with some laterality issues. In particular, was the brain specialized left and right in subserving emotion? And I produced a paper that got published in 78 in Science, which was the first demonstration that the human face was asymmetric in its emotional displays. And that's now been replicated over hundreds of times in many, many societies. It's a fact about us. And at the same time, I started work with Ruben Gura and Norm Geschwin, Geschwin being the father of behavioral neurology, on where lesions were in the brain in cases of pathological laughing and crying. So you could have disorders where damage to the brain would produce these uncontrollable outbursts of laughing and or crying. Where were they? And as it turned out, you could also have those same phenomena occur as a prodrome to seizures. So you have something called gelastic epilepsy, where people who go on to have a frank seizure will be laughing as part of their prodrome, or less commonly, dichristic epilepsy. Well, they'll be crying. And we published that paper in the Archives of Neurology, as well as a sample of people who had half of their brains removed, at least at the cortical level, a hemispherectomy, and what the emotional consequences of that were.
Yeah.
And work also suggested that lateralization played a role in the regulation of emotional expression, positive and negative, that laughing was more common with silent lesions on the right side and crying with silent lesions on the left side. But when it was epileptic, they reversed the
Mm.
laterality, the sides. So when you're putting your foot on the gas pedal, in other
Right.
words, you laughed when it was on the left, but when you were breaking the brake was on the right. And so that produced a model that to this day there are adherents to Davidson's work. Richie Davidson was a colleague and a friend who ran with that type of idea further in claiming very strongly that there are affect is lateralized to left and right centers of the brain.
All right, now I can see obviously where there's a nice setup here to brain stimulation when it's going to show up. But before that, why, from an evolutionary perspective, would sort of happiness and or from a functional, why would happiness need to be on one side of the head and sadness need to be on the other side, or or is that not the right way to think about it?
At all anymore. I don't think anything is nearly as simple or discrete. But the reason I basically, and to this day, I believe we are wired to be depressed and we are wired to be euphoric. That I don't think we could love, for instance, and have attachments to others unless we were capable of experiencing loss, serious loss. And I also still hold the view that what's atypical or abnormal about the depressed state as a psychiatric condition is not the symptom manifestations nor the depth of the manifestations, it's the persistence. That essentially depression is a case of bad breaks. Um, and I think they have to be segregated because only in infancy do you see people laughing and crying simultaneously. In bipolar disorders, you don't see this simultaneous phenomena. You can see rapid cycling where they switch from one state to the other, but these are not states that we simultaneously hold very often. And in fact, there's probably a reciprocal organization that dampens one and ups the other. So it's not a mistake that many antidepressants provoke mania, for instance. It's and so that was sort of my thing. And in terms of wiring level, you can begin to see the circuit diagram. I also think that it is far easier in the human to pharmacologically and through other manipulations provoke euphoria. We have all of these euphoriants around, whether it's opioids or cocaine or on and on. But we have very, very few drugs that will reliably produce depression. I think there's a difference in the extent to which these phenomena are under inhibitory excitatory control.
Oh.
On the other hand, it's the opposite, that you can easily provoke psychologically depression. I did work at one point in my career where I was in the laboratory telling people that they did terrible things to imagine the worst event that ever happened to them and measuring lacrimal flow in men and women, to these types of events. And it was much easier to get them to experience depression than happiness. Yeah, so I don't think that these are independent circuits. But the larger point was in the process of doing this work, Reuben Gore and I had a book contract with McGraw-Hill where we were going to write a book that we never did. And we also never returned the advance. Uh, it was a book called Brain, Thought, and Emotion that was
Yeah.
it was going to essentially review much of the laterality literature in terms of its importance in terms of thought. It's obvious, language, for instance, but also emotion, which was a emerging area.
And around what year was this?
This was 77, 79. I was at Penn from 74 to 77 and was at the age of 25 was offered an assistant professorship at Columbia
Yeah.
in psychology. So I was in the psychology, their only clinician, the only clinical psychologist in that department.
Hmm.
And I had Stan Schachter on one side of me and the chairman of the department on the other, so it was an august position for a very young person. And and I looked in the ECT literature because ECT, number one, and I didn't fully appreciate it certainly at the time, was the most effective treatment we had for severe depression. It also was profoundly effective in mania. It was a technique that very few do both, and this one did both. I just had a review paper in the American Journal of Psychiatry on 80 years of experience treating a mania with ECT. What's that about?
So by late 70s, ECT is already well established.
Oh, well, by the late 70s, it was ancient because it was first used in electrically in 38, and seizure induction as a therapy was invented by von Meduna in 35.
Okay.
First patients were treated in so ECT is like 90 years old in terms of its origins. It's quite
But when it
remarkable.
first came into your sort of focus, it was
Right.
late 70s.
It was the late, yeah, and I had trained as a psychologist, and I thought, my gut sense was EC2 is a terrible thing. That how could you be doing this to people? The first date I had with the woman who became my wife, she asked me out was to see One Flew Over the Cuckoo's Nest,
Okay.
and so there was almost a societal. If you had a bad guy in the field, ECT was it,
Okay.
and but as it turns out. And this is where, as a scientist and also as a clinician, people really have to take a step back. This intervention was by far the most effective treatment we had for these illnesses. It was absolutely life-saving. The patients who were being treated were the sickest of the sick with the illness. They were the people who failed everything else that we had to offer in those days. And they got the most well, and they did it without drugs.
Right.
From as a scientific perspective, what a laboratory for studying the nature of emotion. What was changing in the brain that made this so effective? And from a brain stimulation point of view, it was the only intervention we had at the time that had spatial localization as part of it. There was a raging debate then, less so today, but certainly still there, as to where do you put electrodes on the head in order to produce this effect? And where do you put them to reduce the cognitive effects? The thought and emotion were built into the ECT paradigm because you could do it bilaterally or unilaterally. So, from my point of view, you
Right.
could doing it on the left side as good as doing it on the right side, let's say in treating depression. Very reasonable question because the physiology at the time, I saw this very early on, suggested that ECT was highly lateralized in its physiologic effects. The impact on evoked potentials, on EEG, were clearly lateralized. We did some of the very first work using modern imaging and showed that an hour after ECT, all of the changes you get in cerebral blood flow were on the side of stimulation.
Wait, to put it in context, you're saying at the time it was the only brain stimulation we had that was sort of somewhat regionally targeted. But were there any other brain stimulation at all that does so okay, it was the only brain stimulation in psychiatry and it was also
And
an
neurology.
anatomically targeted intervention in psychiatry.
Right. It was the only form of brain stimulation, period. So, for instance, if you go back to, let's say, 30 years ago, 1995, there were about 250 papers a year on brain stimulation in the world being
Yeah.
published, all of them on ECT. You know, everything else that we have came after.
Right.
And so that was an accident, the brain stimulation part of it. To the ECT was of scientific interest and should be a sign you have something that works that well, and the cognitive effects were profound. Um,
You're talking about
the
the negative cognitive effects.
cognitive effects, yes, yeah, that at the time, around 1980 or so, most of the patients in the world, virtually everybody, was being treated with a sine wave stimulus at the maximum the device put out. And so the consequences of that is the average time it took somebody to know their name, the day of the week, where they were, averaged after a single treatment, averaged about 8 hours with bilateral ECT and 6 hours with unilateral ECT.
And just to clarify, so again, this would be not an optimized waveform. It's a sinusoid, like the kind of thing that would come out of a wall plug.
Exactly.
And there was no titration, meaning no sense of adjusting dose or personalizing it. You just whatever the device provided is what it provided when you activated it. And so therefore, quite possibly people were being provided a lot more energy that was needed. Now, was it so much that everyone was seizing? So you didn't this was still seizure based, right? But it was
Right.
just so much that everyone had a seizure on the first stimuli. Yes.
Yeah, essentially that was true. At the time, I was funded. I wrote a grant in 1979 to do an ECT study, which was a failed study, but it changed the whole field.
Mhm.
Uh, the goal of the study originally was to figure out who needed bilateral, who needed unilateral,
Okay.
to do measures of affective lateralization, to just like we do with language, where I had done some work, for instance, with commissurotomy patients in neurosurgery, where we severed the connections between the two hemispheres and we inject sodium amytal into the internal carotid artery in order to barbiturate that side of the brain for a period. And then we test language on both sides to figure out where that this was called the WADA procedure that Julian WADA invented as part of the troops in Japan after the Second World War. That's where this procedure actually came from, but it's still done to this day. You could see that having a method, because oftentimes, let's say doing surgery for epilepsy, if you leave the patient aphasic, that's a greater deficit than leaving them epileptic, right?
Right. Okay.
Right. So that you need to know this stuff. And so the preposition I had, or the proposition I was presenting, was if we could measure where in the brain depression was it just right-sided or was it bilaterally represented and so on, then we could figure out which of these treatments we needed, sort of a simple concept. And that never worked out. You can't measure that stuff, or I couldn't measure it, never successfully in a way that would be at an individual level reliable, let alone is there really such strong lateralization? I'm very doubtful. By the way, just incidentally, this is what ultimately led TMS, this type of thinking, to do the fast left, slow right.
Right.
For it's exactly it all originated from that you got to either boost the left, increase activation there,
Yeah.
or shut down the right with an inhibitory stimulus like 1 hertz stimulation. That's all out of this original work with Geschwin and so on, and then Davidson, and it's wrong. The TMS as a field never did the critical experiment, the 2x2, because I believe that if you did slow left and fast right, the opposite of what the current mantra is, it would just work as well.
I
Um,
mean, I want to get to the birth of TMS maybe as the child of ECT. If we'll see. The when you talk about this failed study, how are you planning to measure the lateralization? By doing ECT or by some imaging technique?
we were using the same techniques as was being used with language, which worked well in language. Dichotic listening,
Okay.
stethoscopic viewing, as well as imaging results. But beforehand, the idea was to before somebody got started, could you really tell what type of ECT they needed? And that's where the non-invasive measures were developed. And I spent a lot of time up at Yale developing dichotic listening tapes with affective stimuli, and that traditional psychology study that Gazzaniga and others perfected. At the
It's
time,
failed. Sorry, it's failed in the sense that you're not seeing evidence that mood is lateralized, whether it's depression or happiness.
I never developed a technique that I was confident you could measure it if it were lateralized. That it's a prior question. There may be some degree of lateralization to mood. I'm not sure how important it is, but it was a failed study because we did something smart. And this was purely to do better science so that the art of the science was better. I went to the experts in the field and asked, so how do you decide where to set a dial on this thing?
Hmm.
Incidentally, this is a very different era. I was funded. I wrote the grant with Sid Mallitz, who was a psychiatrist at the Psychiatric Institute at Columbia, who needed somebody who was working in science and who had an interest in ECT. And Rochelle Gittleman Klein, Don Klein's wife, great scientist on her own, Rochelle, she was the one that was the matchmaker between Sid and I. And I went around to Max Fink and to Gabrams and the others in the field and asked them, so how do you decide where to set the dial on this thing?
Okay.
They could not produce a rational answer.
Hmm.
And and there was no information on individual differences in seizure threshold, like you were asking, do people differ in their needs and so on? And out of the blue, I was trying.
And at that time, there was bilateral and unilateral already?
Unilateral was first used in England in 1956.
Okay, okay.
And there were many different unilateral placements. There was uncertainty as to where on the right side you would put the electrodes, and bilateral is always from the original Cerletti and Bini in Italy placement because the thickness of the skull is less over these temples, and
Yeah, yeah.
many tongs. That was the original justification for that position. Now there's also a bifrontal, and we know, from much of the modeling work that where you put these electrodes makes a huge difference, particularly with something like ECT.
But you're
So
saying the original lateralized, they were already all going right. So there was a sense early on, very early on, that you wanted to go right.
Liz Warrington, a great neuropsychologist in England, did work where she showed she was as good as that WADA test, right? Using left and right unilateral ECT on the same people to identify site of language, right?
Well, right and left was about avoiding side effects, not about treating the depression.
Right. Yes, the rationale was for the reduction of side effects to avoid language centers is why they went side.
Okay.
And there's always an issue. What if you have, you're left-handed? Should you be then doing it on the right side, left side, and so
Okay.
on?
All right. So then there's right, there's left ECT, but everyone's getting either full dose or who knows what, and you're going around asking practitioners what's their rationale for how they adjust intensity, and no one has an answer.
And I was fortunate because I was working with number one, a brief pulse device.
Right.
So that already was a huge step from the sinusoidal waveform,
Right.
where you could control the stimulus in a way that you certainly couldn't with the sinusoidal. And the sinusoidal was a constant voltage stimulus, and just in terms of the technicalities, whereas the brief pulse already was a constant current stimulus, which made a lot more sense in terms of the physics of the stimulation. That essentially, if the current was the active ingredient in inducing the seizure and producing the therapeutic and side effects of the treatment, that's what you wanted to dose in. With a constant voltage, you don't know what the current was in the brain because
Right, right.
you're just controlling the voltage and letting the current vary. So impedance will
But at
determine.
this point, we're still at a titration, right? There's essentially there's constant voltage and no titration.
There's no titration at all at this point, and in the first patient treated with this with the ECT that I did at Columbia, um, we introduced titration.
Okay.
And being trained as a classical psychologist, and in working in psychophysics labs and so on, the issue was: Am I going to titrate from top down? Am I going to titrate or ascending or descending or mixed?
Uh-huh.
You know
Okay.
how And what made the most sense in this context was an ascending titration, ascending method of limits, so that I would increase the stimulus intensity under anesthesia until I reached the threshold for a seizure.